what to do if the headache is not a migraine headache? So what other things can cause headaches? And when you actually need to worry and need to ask your doctors maybe for some tests. So secondary headaches, post-traumatic, somebody had head trauma, regardless of the severity of the trauma, person can develop headaches. And sometimes the mildest trauma actually patients with mildest trauma end up having more severe headaches than the ones who have more severe trauma. Vascular disease such as aneurysms, malformations, dissections of the blood vessels in the neck, blockage of the veins in and around the brain, cerebral venous sinus thrombosis, or even sometimes strokes can cause headaches. Other intracranial pathologies, so something else sitting in the brain, it could be tumor growing there, either benign such as meningioma or cancer or metastasis. It could be blood. Somebody fell or hit their head and has subdural hematomas, especially older people. It could be abnormal pressure of the spinal fluid, either high or low, or hydrocephalus. Substance use, both prescription and non-prescription. So prescription, medication overuse, but certainly cocaine can cause headaches. Some other illegal substances, amphetamines, can cause headaches. Infection, meningitis, encephalitis can cause headaches. Homeostatic disorders, hypoxia. And what could cause hypoxia? Certainly when somebody has COPD, their blood oxygen is low, but sleep apnea can cause headaches. High blood pressure can cause headaches. Thyroid dysfunction, both high and low thyroid hormones can actually cause headaches. So we do quite frequently check thyroid hormones, especially if we have already migraine patients and their headaches have changed and we don't have any good rhyme or reason. Certainly headaches can be coming from the neck. Somebody has arthritis in the neck. Eye problems such as glaucoma, ear issues, nose problems, throat, mouth, teeth, TMJ, sinus issues. And then we have what's called cranial or facial neuralgia, such as trigeminal neuralgia. So post-traumatic headache usually is closely related to the head injury. Usually begins within a day to 7 days, week after the injury, although I always tell my patients, well, if you were in coma for 3 weeks, I'm not going to count those weeks because who knows what was happening then. Or if somebody was taking lots of pain medications for other pain that actually could mask onset of the headache. Usually these affect both sides of the head, constant, mild to moderate. They can have features of either migraine or tension type headache. And again, degree of the trauma actually does not correlate of the degree of intensity of these headaches. Many of these patients have associated symptoms. They can have dizziness, they can have vision changes, ringing in their ears, difficulty with memory, difficulty paying attention, concentrating, sleep problems, and depression and anxiety. They can have alteration of taste and smell.
Can you have those with migraine as well?
Symptoms?
Trouble concentrating?
Yes, during the headache attack, but with post-traumatic headaches, they usually have even when they don't have headache.
Okay.
But yeah, with the migraines, during migraine attacks, certainly even thinking hurts.
You can't concentrate or remember anything.
So with the high and low pressure headaches, so usually these are associated with certain positional changes. So if somebody's spinal fluid pressure is high, these headaches tend to be worse when somebody is lying down. So at night, early in the morning, tend to get better throughout the day. If somebody's spinal fluid pressure is low, it's opposite. So headaches are better when person is lying down. So if somebody has ever had lumbar puncture, spinal tap, and had headaches afterwards, so if you lie down, headache is better. You get up, a few minutes or half an hour later, you start getting headache. And as the day progresses, headache gets worse. Both of these, both low and high pressure headaches, can be associated with double vision. So high pressure headaches, again, usually worse at night and in the morning. People can have some brief visual obscurations. They can have brief episodes of blurred vision, vision changes, sometimes preceded or precipitated by coughing, sneezing, straining, using bathroom. They can have swishing sounds in the ears. They can hear pulse in their ears, can have double vision, visual loss, nausea, vomiting. Sinus disease, not a common cause of headache. So as Dr. Ali mentioned, up to 40 million of people in the United States have migraine headache. Only half of them are actually diagnosed. Other half think that they have sinus headaches. So Sinus headache, so headache with the sinusitis, is actually a minor diagnostic criteria for sinusitis. If somebody has sinus inflammation, acute sinus inflammation, they should have fever. They should have yellow, greenish, thick discharge coming out of the nose or at the back of the throat. And usually these are headaches lasting for a couple days or even weeks. If somebody is having sinus headaches once or twice a week and they don't have fever, they have only some clear nasal discharge, most likely they have migraine headache. Headaches coming from the neck, usually, again, if the headache is either brought on or getting worse with certain head or neck movements or position, could be from the neck. Usually starts in the neck and goes up, can affect one side more than the other. Occasionally can radiate to the eye, so coming from the back and going behind one eye. Again, as we talked, sleep apnea can cause headache, and up to half of the people who have sleep apnea can have headache. These headaches are, again, more pronounced at night or early in the morning, and as one gets up and gets about and around, headache can get better. Eye-related headaches could be either due to eye strain, so right now everybody is using little iPhones and trying to see things there, or from glaucoma, so increased pressure within the eye. Usually with these headaches, though, there will be some halos around the eye, sometimes even redness of the eye and swelling of the eye. Headaches from the TMJ dysfunction tend to radiate to ear, jaw, can be associated with actually clicking in that jaw on that side, ringing in the ear. And then, as Dr. Ali mentioned, so medication overuse headache, you never can emphasize this too much. So again, I do tell my patients most of the time, don't take as needed medications more than 2 days a week, regardless of the medication. Again, opiates and Fioricet, if somebody's taking those, I also say 1 to 2 days a week. And even if you're using NSAIDs, ibuprofen, Advil, that are thought to be safe up to 15 days a month, so up to 3 days a week. I usually tell my patients, if you notice that you need to take medications more than 2 days a week, let me know, because we might need to adjust your preventive regimen. So when to worry about your headaches? So if this is the sudden onset, you have never had headaches before, and you have this certain thunderclap headache, this is the worst headache in the life, you need to see doctor, go to emergency room. If there's a sudden change in the character or pattern, so again, you were having 1 headache a month and suddenly you have 4 headaches a week without any rhyme or reason, or headache feels completely different from your usual headache. If this is a new onset headache after the age of 50, if headache is associated with fever, confusion, weakness, numbness, vision changes, or if you have any other underlying conditions such as cancer, so we always worry if the cancer maybe spreads to the brain, HIV, or autoimmune disorder that can decrease your body's ability to fight infections, and then we worry that maybe new onset headache is due to some infection. So again, this thunderclap, sudden lightning type headache, we mostly worry about subarachnoid hemorrhage, bleed around the brain. So again, go to emergency room, call EMS. Subdural hematoma, usually in elderly patients. There's some history of head trauma, sometimes even weeks or months preceding this headache. And patients also can have some weakness, numbness on one side of the body. If somebody has tumors, something growing in their head, headache is usually sort of gradual onset and gradual worsening. It's not going to happen overnight. So usually gradual worsening over days, weeks, and again, one can have weakness, numbness, vision changes, confusion. There's a condition called temporal arteritis or giant cell arteritis that's mostly seen again after the age of 50. People can have, in addition to the headache, some visual changes. They can have pain in the jaw, mostly when they try to eat, talk, and then if they rest, pain can get better. They can have fever, night sweats, weight loss. They can have some muscle aches in the shoulders. So again, if anyone has these symptoms, we usually worry and you do need to see a doctor. Chiari malformation, lots of people who have migraine headaches at some point in their lives gets imaging and they are told that they have Chiari. And now their question is, so why are you treating as a migraine headache if I have Chiari? So most of the time, this is what we call incidental finding. Headaches that are due to Chiari malformation are usually induced by straining. So if somebody says my headache is brought on by coughing, sneezing, straining, bending over, and then there are some associated other symptoms, it's Chiari. But if headache just gets worse by these symptoms and you already have it, most likely it's your migraine. Again, meningitis usually is associated with fever, stiff neck, and then headache after spinal tap is usually better when somebody is lying down and worse when somebody gets up. So diagnostic testing, when do you need and what do you need? Severe sudden onset headache, usually people end up in emergency room. We get head CT because it's a very quick test. We can get it over 5 minutes, and it does show if there's any acute bleeding in or around the brain. If somebody has more chronic headache, we do prefer MRI because MRI brain shows more detail of the brain, and especially back of the brain we can see better. If we are considering that there could be some blood vessel abnormalities, we'll order blood vessel studies, so-called MR angiography, MR venography brain, or CT angiography, CT venography brain. If we are suspecting, again, bleed around the brain, if we are suspecting infection or high pressure headache, we will usually order spinal tap or lumbar puncture. And then we do order labs to assess for any other systemic diseases, nutritional deficiencies. So again, if we are suspecting inflammation, we'll check inflammatory markers. As I mentioned before, we usually check thyroid function. We look at the electrolytes. We look at the blood counts because both high and low blood counts can actually cause headache or worsen headache. So again, when to think that you actually need imaging? If you have had the same headache for past 20 years, most likely you don't need any CAT scans or MRIs. But if this is the first or worst headache in your life, certainly. If again, there's an increase in headache frequency or severity over the weeks or months without any good rhyme or reason, without medication overuse. If somebody has chronic daily headache that's not responding to treatment and all the other causes have been ruled out. If headache is always on the same side, it never switches, because yes, migraine tends to affect one side, but occasionally it will switch over. So the people will say, it mostly hurts on my left side, but once or twice a year it might switch over to other side or affect whole head. If, again, headache is not responding to the treatment, or if this is a new headache, again, in patient with cancer, HIV, immunosuppressed patient, new headache after the age of 50, or if headache is associated with any other neurologic symptoms, weakness, numbness, seizures, stiff neck, fever, confusion or cognitive changes, or if a headache is brought on, as we talked before, with exertion, coughing, sneezing,